Dear students, today we're going to discuss about the axillary nerve and its injury. Okay, axillary nerve course and its injury. This is also very important topics in exam. Let's see one question over here. This question says 32-year-old female sustains a proximal humerus fracture shown in the figure, right? So she has the fracture. It is shown in this region, right? So this is the fracture region over here. It is shown over here, and the fracture goes an uneventful union, but she complains of a lack of sensation. This is important. Lack of sensation of the lateral deltoid. Okay, lateral deltoid. So we have the lack of sensation over this region, lack of sensation here, right? And then has weakness in the Hornblower's test. Hornblower's test. So we have to understand some few points over here. Which of the following structure is most likely injured in this case? Look at here, lack of sensation of the lateral deltoid. This is supplied by the axillary nerve. That is supplied by axillary nerve with the dermatome root value C5 and C6. Okay, and Hornblower's test is positive in case of teres minor muscle injury. That means the Hornblower's test is the test done for the teres minor muscle. This is also the question in the exam. And teres minor muscle is supplied by the posterior branch of axillary nerve. So we have the answer over here, posterior branch of the axillary nerve. So that should be the answer. Okay, look at here, we have the axillary nerve. This axillary nerve is coming below the glenoid cavity, and then it's giving branches over here, right? So it's passing posterior. This is the posterior aspect of our shoulder and scapula. So you can see this is posterior side, the axillary nerve is moving, right? And actually in this region we have the quadrangular space. Okay, this quadrangular, from this quadrangular space the axillary nerve is passing back. This is very important question. Okay, because we have here the quadrangular space, the triangular space, like this forming, right? So we have the quadrangular space, triangular space, quadrangular, triangular, and triangular, right? So they will ask you the question in the exam. So look at here, the origin of the axillary nerve. How is it originated? This is our root of the brachial plexus, trunk, divisions, course, and we have the branches, terminal branches here. So see, the upper, middle, and lower trunk, they give the posterior divisions over here. All the posterior division forms the posterior cord, and the posterior cord gives you the axillary nerve, right? So this axillary nerve is following the posterior cord. From the posterior cord it carries, see, this posterior cord is carrying the root value from this C8 T1 also, C7 also, C5, C6 also, but the nerve fibers which are going to our axillary nerve is going from the upper trunk only, that is C5 and C6, so that the root value for axillary nerve is C5 and C6. So what's the origin? The origin is from the C5 and C6 root going to the upper trunk. From this upper trunk is going to the posterior cord. From the posterior cord it gives the axillary nerve. So what's the origin? We understand. In the origin we have to understand here root value is C5 to C6. From this it's going to the upper trunk. From the upper trunk it is going to the posterior cord. This posterior cord is giving you the branch as the axillary nerve, right? So this is the origin, and the root value we already discussed over there, that is C5 and C6. This is question in the exam. Okay, this is also the question in the exam. Go forward. So what's the course? Look at here, the course is here, like our axillary nerve is exiting from here. Okay, is coming down this way and it enters to this quadrangular space. This is our quadrangular space. You can see here quadrangular space. This is the quadrangular space. Okay, so from this quadrangular space it goes posterior to the humerus, surgical neck of the humerus, as you can see this in this image. So it's passing from this corner of your scapula. Can you see? This is the what is this one? The superior angle of your scapula. It's passing like this, and if you remember we have the clavicle over here. Okay, so this is our clavicle here, passing below the clavicle, and it is this is our subscapularis muscle. So it is anterior to the subscapularis muscle, and if you remember here we have the axillary artery. Okay, so it is passing posterior to the axillary artery, anterior to my subscapularis muscle, and below the clavicle, as the posterior cord is below the clavicle, and it enters to the quadrangular space below the glenoid cavity, right? So and then it circles around the surgical neck of the humerus. So this is the surgical neck of the humerus. So what's the course? Let's see. The course is very easy. It originates from the posterior cord, passes anterior to subscapularis muscle, posterior to axillary artery, enters to the quadrangular space, and from the quadrangular space below the glenoid cavity, it circles around the surgical neck of the humerus. That's the course. So what's the course? We can see here the course is that originate from C5, C6, finally posterior cord, and this gives the branch of axillary nerve as anterior to my subscapularis muscle, and it is posterior to the axillary artery, and then it passes below the glenoid cavity, and then enters to the quadrangular space, and then circles around the surgical neck of humerus posteriorly, right? So this is the course we understand right now. And then look at here the quadrangular space we have. In this quadrangular space, we can see the quadrangular space as the teres minor here, teres major here. This is the long head of the triceps, and here we have the humerus, right? So how can we draw this picture? It's a very simple picture like this, and like this you can draw, right? So and here should be your what? Here should be your scapula. Okay, so scapula is like this, so that you can see over here, this is my teres minor, this is my teres major, this is my humerus, and this side, this is my long head of triceps. Okay, so in between these structures we have these spaces. So see, this is my upper quadrangular space, and this is my upper triangular space, this is my lower triangular space. So see, this is upper triangular space. It has 1 2 3 4 boundaries: teres major superiorly, teres minor inferiorly, and this is my long head of triceps medially, and this is my humerus laterally. Upper triangular space has the boundaries as we have the teres minor here, teres major here inferiorly, and laterally we have the long head of triceps. Lower triangular space similarly has the boundaries as this is my humerus laterally, medially long head of triceps, and then superiorly I have the teres major. So these boundaries, these are the questions in the exam. Question, and here also question, here also question they will make, okay, the boundaries. And then they will ask you what are the structures passes through these spaces. We have every space has 2 structures passing. Okay, so understand, this structure is passing above to the head of the humerus. These structures are passing below to the humerus. These structures are passing to the scapula. This is the dorsum of the scapula. We are looking the scapula from backside. Okay, so likewise we can see here 2 structures going, these 2 structures going, and here 2 structures going, right? So like this, as we have this, here we have the lower triangular space, here we have the upper triangular space, and here we have the quadrangular space. So these are the 2 structures going over here. These 2 structures are circumflex humeral artery, and this is my axillary nerve. And going below these 2 structures, one is radial nerve, another one is the profunda brachii artery. And here we have the 2 structures. These 2 structures, they are going to the scapula like this, right? So this is my circumflex scapular artery and circumflex scapular vein. So that these are the structures they are passing over here. So they will ask you in the exam, so that our axillary nerve is passing through the quadrangular space. Okay, so this is the question in the exam. Now let's see the branches and supply. So to see the branches and supply, as we know, the axillary nerve originate from C5, and C6. So these are the root values, right? So from these root values it forms the axillary nerve down, and this axillary nerve, before reaching to the quadrangular space, it gives one above branch. This is the glenoid branch. Glenoid branch to the glenoid cavity, and then it enters into the quadrangular space. So from this quadrangular space it divides into two branches like this. Okay, so one is the anterior branch and one is the posterior branch. So this is my anterior branch, this is my posterior branch, and this is my quadrangular space. So from the posterior branch it gives one branch to the teres minor, and from this posterior branch and anterior branch both combinedly gives one branch to this muscle. This is my deltoid muscle, and here is my teres minor muscle, right? So they are supplying deltoid muscle combinedly. And finally this posterior branch is giving the upper lateral cutaneous nerve of arm, and it is supplying the upper lateral cutaneous nerve. It is supplying the upper deltoid over this region, the skin. Okay, and here also I have this, the anterior branch also giving the cutaneous branch. This cutaneous branch is supplying the anterior lateral, okay, anterior lateral of the arm. So finally these are the branches of the axillary nerve. So what are the branches right now we discuss? They originate from the C5 and C6. Like this, it's an axillary nerve. It's giving first the glenoid branch. Glenoid branch is going to the glenoid cavity, and then it comes to the quadrangular space. Quadrangular space, it divides into the two branches, one anterior branch and one is posterior branch. Posterior branch is going to the teres minor. Anterior and posterior branch both are supplying to my what? Deltoid muscle over here. And then finally the posterior branch gives the upper lateral cutaneous nerve, and the anterior branch also gives the anterior lateral cutaneous branch, which is supplying the sensory, doing the sensory innervation, right? And what's the function of these muscles supplied? So teres minor, it supplies the teres minor. Teres minor causes the lateral rotation of arm, and deltoid muscle is causing the abduction of shoulder 15 to 90 degree. This is the question in the exam. First 0 to 15 degree of abduction is done by my supraspinatus muscle. This is question in the exam. 0 to 15 degree abduction by supraspinatus, 15 to 90 degree by the deltoid muscle. So this is the question in the exam. So hope you understand. Now let's go to the injury to the brachial plexus, the axillary nerve. So the injury to the axillary nerve we divide into three different categories. One, we can say quadrangular space syndrome. Quadrangular space syndrome. That means the axillary nerve is compressed. Axillary nerve is compressed in the quadrangular space, right? So what are the causes? The causes can be like overhead athletes, common in the overhead ATS, LETS, overhead athletes, or we may have the muscle hypertrophy, or we may have the muscular cyst, like muscular cyst. This can all produces the quadrangular space syndrome. That means they can compress the axillary nerve over the quadrangular space from where it passes. Just now we discussed the quadrangular space we have over here, right? So in this space the axillary nerve can get compressed. So this is one of the cause. The another causes can be the iatrogenic injury. IATROGENIC, iatrogenic injury. That means instrumental injury. What is this one? Instrumental injury to the axillary nerve, right? So what are the causes of the instrumental injury? So one cause can be the arthroscopy. They will ask you in the exam. So arthroscopy most commonly causes the posterior branch injury. That means the teres minor is most commonly affected. Another cause can be the IM injection. IM injection in deltoid, right? So this IM injection can cause the anterior branch injury. Okay, so this I will show you the safe zone in the arm, how to inject intramuscular injection, right? So these are the iatrogenic causes. Another can be the accidental injuries, like we have accidental injury. This accidental injuries can be the surgical neck fracture, like surgical neck fracture, because we have the humerus going like this, right? And in this humerus we have the axillary nerve passing this way, so that this is the surgical neck. If the surgical neck fracture, then it can cause the injury, right? So, the axillary nerve injury. Similarly, if we have the inferior shoulder dislocation, this is also the important question they will give you in the exam. Inferior shoulder dislocation, which nerve is most commonly injured? That is axillary nerve. Okay, and surgical neck fracture, which is the commonly injured nerve? That is axillary nerve. Okay, this is the question in the exam. These are the question everywhere they make you the question. Arthroscopy of the shoulder, what is the most commonly injured nerve? Intramuscular injection in the deltoid muscle, which is the most commonly injured nerve, right? These are the question in the exam. In the quadrangular space syndrome, what is the most commonly injured nerve? This is the axillary nerve. So they will ask you these multiple questions from here, and right, so this is the inferior shoulder dislocation. It causes what? The axillary nerve injury. So these are the causes of the axillary nerve injury. So if we have the axillary nerve injuries, what is the weakness? I'll show you the weakness over here. A presentation I'll show you. Before going to that, let's see the traditional safe zone. What is the traditional safe zone? See, our axillary nerve is passing over here in the surgical neck. So if you measure the distance from the acromion process below 5 centimeter, this zone is the traditionally safe zone. You can inject the intramuscular injection within this region. This 2 centimeter distance, is the danger zone where we have the axillary nerve. So these are the chances of injury to the axillary nerve. Is that clear? So hope you are clear. I think so, right? So what is the traditionally safe zone? That means 5 centimeter from the acromion process. So what is the traditionally safe zone? Traditionally safe zone means 5 centimeter from the from the acromion process. Why we call this traditionally safe zone? Because axillary nerve passes between 5 to 7 centimeter from acromion process. So it passes between 5 to 7, that means within this 2 centimeter from here axillary nerve passes. So that up to here, this 5 centimeter is safe zone, 5 to 7 centimeter this is unsafe zone, right? So if we inject over here, we will commonly injure the anterior branch of the axillary nerves, as this picture we can show here. So what's the presentation of the axillary nerve injury? The presentation is, you can see over here, we have the the motor presentation, some we have the sensory presentation. In the motor loss, we can see two things, as like deltoid is paralyzed, so that abduction to 15 to 90 degrees lost. Another one, we have the teres, minor injury. That means lateral rotation is weak, right? What's the sensory loss? You can see the sensory loss is over here. That means the lateral superolateral shoulder sensation is lost. Similarly, you can see some other presentation in the picture. This is you can see this side deltoid and this side deltoid. So this is called the flat shoulder. You can see loss of sensation over here, and you will see the atrophy of your deltoid muscle. Like this side, you do not see this kind of atrophy, but this side you can see the atrophy, right? So this is the long-term presentation. Okay, so these are the presentation of our deltoid axillary nerve injury. So in the axillary nerve injury, deltoid affected and teres minor affected. Deltoid affected, then 15 to 90 degree the abduction is lost, and teres minor affected, then you will have the weakness in the lateral rotation, sensory loss over the superolateral part of your deltoid, your arm. And test we can do, this test is called the horn blowers test. So what do we do over here? Look at here, we abduct the shoulder or arm into 90 degree and flex the elbow in 90 degree, and then we request the patient to maintain this position, but patient cannot maintain this position, and this will be rotated medially. Like, see, you can see this is rotated medially, as like the thumb goes near to the mouth, as like she is trying to blow the horn, like she is trying to blow the whistle. So why is this? Because she cannot maintain this lateral rotated position because she has the teres minor injury. So that teres minor is weaker. That means axillary nerve injury producing the teres minor weaker, so that it will be medially rotated as like this. Okay, so that she will produce the Hornblower sign positive. So that question in the exam is that Hornblower's test is positive or Hornblower's test is done for teres minor muscle. So remember, this is the question in the exam. Okay, and see, this is the same question we just discussed, and we had this problem over here in this patient fracture, and Hornblower's test was here. That's why we choose what? The teres minor muscle. Teres minor muscle is supplied by what? The posterior branch of the axillary nerve, just now we discussed. And we have another question over here. In this 21-year-old infantryman dislocates his shoulder during basic training. That means shoulder dislocation. Yes or no? He is able to make it through training but continues to experience recurrent dislocations and anterior glenoid bone loss. And your sports colleagues indicate him for a Iatrogenuc procedures. This is a surgical procedure to repair the recurrent dislocation of the shoulder. The procedure successfully restores stability to his shoulder, but the patient is referred to your office just over 3 months later because he has persistent difficulty with abduction. So look at here, patient has difficulty in abduction when the arm is internally rotated because teres minor is involved, so that patient cannot do the lateral rotation, right? So that is internally rotated, an abduction problem. So you suspect an iatrogenic nerve injury sustained during anterior shoulder exposure and offer him a nerve transfer procedure involving the branch of the radial nerve that innervates the medial head of the triceps. The nerve that is injured in this patient innervates what muscle? That means patient has the problem with what? The internal rotated, that means lateral rotation problem, and patient has the abduction problem. That means these two muscles are deltoid muscle and teres minor muscle. That is supplied by which nerve? The axillary nerve, right? So axillary nerve is supplying the deltoid muscle plus teres minor muscle. So that we should understand this is the case of what? Axillary nerve injury. Another point from the same question they can make is that they use the nerve transfer procedure to the axillary nerve. Which nerve is used? That means we use the branch of the radial nerve. The radial nerve to the medial head of the triceps has two branches, so that if we do the nerve grafting, one branch of the medial head of the tricep can be grafted to the axillary nerve. So this is also the question in the exam, right? So they will give the option, the nerve to medial head, lateral head, or the long head of the triceps. Which can be used for the grafting? The answer should be what? The nerve to the medial head, because medial head has the two branches of the radial nerve. That's why we use as the grafting procedures. So the answer here in this question should be the axillary nerve. We discussed already in the case. So axillary nerve is supplying which muscle? Supplying the deltoid muscle and then the teres minor muscle. Well, do we have the option that is the deltoid muscle and the teres minor muscle? So hope you understand. Thank you very much for watching. Keep following and keep subscribing. Thank you.